Hello, my name is Sam Feltham. I'm the Director of the Public Health Collaboration and welcome to the PHC Virtual Conference 2020. The coronavirus has changed all of our lives, but where there's an obstacle, there's also an opportunity. And that opportunity comes in the guise of this virtual conference. Earlier this year, we had to postpone our two main events, the annual conference and the Real Food Rocks Festival, until next year. These events allow us to connect, learn and grow, but they also help us raise crucial funds for the PHC to continue. With that in mind, and before we let the next presenter speak, this virtual conference is 100% free for all. But if you find the content valuable today, then please consider donating £2 or whatever you can afford through the Total Giving website via www.phcuk.org/donate. Or if you're in the UK, you can simply text PHC to 70660 to donate £2 directly from your phone. We hope you enjoy the conference from wherever you are in the world, and be sure to get involved in the civil conversation on the comment section here on YouTube or via the hashtag PHCVCon2020 on Twitter, Facebook and Instagram. Thanks for your support, take care and stay safe.
Hello there, my name's Ayan Panja. I'm a GP in St Albans in Hertfordshire, and I am delighted to be joining you for this public health conference, albeit virtually. I'm going to be talking a little bit about my world, which is in general practice, and how as practitioners we deal with the future that lies ahead. It's safe to say the world is a completely different place now compared to even 3 months ago. And it moves me just to think about the amount that the healthcare system, the NHS, has had to adapt so quickly in the last 3 months to deal with the crisis that we all face. So really, when I think about the current state of play, the world that we're living in now, these are the kind of things that fill my mind, and I'm talking from a personal point of view. It moves me to tears when I think about the NHS staff that have given their lives to fight this virus, and colleagues of mine that day in, day out actually go into work really at the very front line, risking their lives, and all the unseen work that goes on in terms of carers, looking after our elderly population who have become lonely and isolated, and we know how bad that is for your health. And also, you know, the political messaging and the pressures, the commercial pressures on the government to get back to some semblance of normality. You can't furlough people forever. And then there's that side of things. And then also people with young families who are trying to cope with schooling their children at home. You know, it's a cliche, but it is a new normal and we're all trying to get used to it. What I'd like to do is really take a look at how this has changed the face of general practice and what we're going to be able to do in the future as practitioners to prevent the burden of this disease. I'm not just talking about the fallout. The fallout is going to be enormous. There are going to be people with tremendous amounts of anxiety, related disorders, a lot of diagnoses that are in waiting at the moment because people aren't accessing healthcare in quite the same way. And I'm not talking really about that. I'm talking more about this current crisis and how we can actually improve our health as a nation so that we don't succumb to this in the way that we have been. So I want to start with what looks like quite a technical slide. This is hot off the press. This is Ben Goldacre and his colleagues' paper that has been published literally days ago. And it looked at 17 million adult NHS records in terms of hospital deaths which were related to COVID-19. So if you look at this graph here, which is a plot in terms of hazard ratios, in terms of the likelihood of risk factors affecting your chance of dying from COVID-19 infection, you can see that there are factors here that you can't do anything about, like age, sex, and ethnicity. But a lot of modifiable factors in terms of things like diabetes, chronic respiratory disease, chronic liver disease, stroke, dementia, essentially non-communicable diseases. And you can see that these plots that are to the right of the red line, that means that these factors increase your risk of death. So interestingly, actually, in this particular study, high blood pressure seems to not increase your risk, but we'll come back to that perhaps later on. But you can see things like reduced kidney function, stroke, diabetes, all of those things push you to the right-hand side of that red line, which means they increase your risk of death from COVID-19. And this is from another study that was from a few days prior to that, the Biobank study from Glasgow. It had a smaller sample size. This is slightly different because this is about the risk of actually catching the virus itself, which is more to do with, so not death, but actually more to do with what we call morbidity, so illness. And again, the risk factors are very similar. Black ethnicity seems to increase your risk. There's an interesting one here about slow walking pace, male sex, and in this study they looked at blood pressure medication as a marker that you had high blood pressure. Arguable, so sort of an indirect measure, and that seems to increase risk. So if you're on blood pressure medication, that seems to increase your risk. And cancer and diabetes, and again, very similar. So lots of non-communicable factors there. What I think's happened with this COVID-19 crisis is that chronic conditions, chronic medicine has suddenly become acute. And by that, I mean that there used to be a distinction between acute and chronic medicine, and any of my patients that have long-term conditions, you know, we're doing the best that we can in terms of lifestyle measures and medication to manage those conditions. But all of a sudden, the people that have those chronic conditions have suddenly, a lot of them have become ill and died, or become very, very unwell. So the acute and chronic medicine have become blurred in a way that I've never known in my 20 years of medical practice. And this paper just shows us, you know, I flashed up the title because the key factors in COVID infection are really immunity and inflammation. So in some ways, it's not the virus that causes us to become ill or kills us, it's actually our own immune response. So how does the SARS-CoV-2 virus actually affect our immune system? So it causes this syndrome that we call COVID-19. Well, here on the left in blue are all of the components of your immune system in terms of processes that need to be functioning well in order for us to come up with an appropriate immune response. And that's the key here. So if you react appropriately, if your immune system's working very well, then you probably won't get the virus at all, because this mucosal immune system refers really to barriers. And they're things like our mucous membranes, you know, these linings like this red part here that I'm just exposing on my eye, that line our nasal passages and our lungs, and, you know, contain immunoglobulins like immunoglobulin A, and if you're secreting those appropriately, then you won't get the virus in the first place. Then there are all these functions, you know, Treg cells and cytokines, which are part of your inflammatory response. And if that is appropriate, you can defend yourself perfectly well. So this diagram here shows the SARS-CoV-2 virus attaching to an ACE2 receptor. ACE2 receptors, remember, is how the virus gains entry into the body. They coat a number of cells in the body, which are found in different organs, very much in the lung and the gut, but other organs as well. And then, so I've lost my cursor there, then you'll see that these inflammatory mediators are involved in this process of the virus getting into the cell and you forming an immune response. So this is your innate immune system, the kind of immune system that kicks in when you have a cold. It has no memory, and in this case, because it's never come across this virus before, because it's a new novel virus, it relies heavily on your innate immune system. Now you can see in the top part of this diagram here, that if you have an appropriate immune response, then you make natural killer cells. Natural killer cells recognize the virus in your cells and essentially release chemicals to clear the virus. And then you can end up later on forming antibodies, in terms of antibodies to the infection, which is part of your adaptive immunity. So it will recognize the virus again. But here at the bottom, you can see that if you have risk factors, so it talks about host factors here, like age, smoking, diabetes, all the things that we looked at in that previous slide. It doesn't include things like ethnicity, but clearly that is a factor here. Then you end up with something called hyperinflammation, and all of these cytokines and interferon, all these sort of inflammatory mediators are inappropriately activated, and you get too much inflammation, and that overwhelms us and causes things like respiratory distress and multi-organ failure. So what has this got to do with healthy living? Well, the answer is really everything, because in order for us to cope with the insult of a virus like this, you need more immune resilience. And just a quick recap on the difference, if you like, but also the collaboration between medical and lifestyle models, is that the lifestyle medicine approach is individualized. So the medical model very much depends on protocols. If you think about your local secondary care clinic, whether it's gynecology or gastroenterology, they tend to have pathways for diseases and conditions rather than people. And the lifestyle approach is really based on looking at physiological systems and is very much focused on prevention, which is what we're talking about here today. And it's not just about diet and exercise. People who are cynical about lifestyle medicine will say, well, it's common sense. I mean, just eat a bit better, run a bit more, go to the gym. Would that it was so easy. And you've got to remember that in a way, the lifeblood of lifestyle medicine is diet and exercise. I'm not poo-pooing them, but there's a lot more to it. Relaxation, for example, in your mindset, how you deal with stress, very important. Sleep, massive. Your environment, where you live. Are you living next to a quarry or somewhere that is poisoning you with toxins? Those things are very important. And of course, your genes, which play a role as well. And when you think about the systems that all of these factors on the left-hand side affect, well, they affect all of the systems in the body. And this is not exhaustive, because a lot of people say, well, hang on, you haven't got skin on there. But your gut and your immune system, which are almost synonymous, because most of the immune system lays within the gut, 70 to 80% of it, your endocrine system, your nervous system, cardiovascular system, and your musculoskeletal system. You could think of cardiovascular as cardiorespiratory, because they're often considered together. And the key thing is that all of the things that you do on the left directly affect the systems on the right. Just to sort of bring this home to you, if you think about a time when you perhaps stayed up very late. So for me, when I was revising for exams at medical school and I'm cramming the night before, I'd do an all-nighter, I'd drink lots of coffee, and I'd stay up and I'd feel absolutely terrible. So my heart would be racing, my gut would be wrenching. And that is sort of an acute version of what happens to your systems in the longer term if you're not doing these things appropriately. So if you're getting no sleep, you're eating all the wrong food, you're not able to relax, then you will become ill. And the way you become ill is because of a malfunction of these systems. Just to slightly labor the point, a lot of people think about type 2 diabetes or insulin resistance as something that's directly related just to food and movement. Well, actually, there are lots of other factors. So this is just a schematic on how sleep and disruption in sleep can actually lead to insulin resistance. And we know that there are studies that show that even 6 weeks of poor sleep will nudge you into a state of insulin resistance. So Actually, even 24 hours will to some extent, because it has such a massive effect on all of these pathways in terms of cortisol, and it's pro-inflammatory as well. Here's a study on stress and insulin resistance. Again, something that has been largely ignored by the medical community. We've become very, very focused on, exercise and diet. Yes, they're very, very important, but stress is also important when it comes to insulin resistance. And I'm just using that insulin resistance as one of many, many examples of a non-communicable condition. So as we're talking about non-communicable conditions, I'm finding that hard to say at the moment, aren't I? Non-communicable disease is really the biggest sort of killer in terms of global deaths. 71% of all deaths globally are down to NCDs. And again, we see the same sort of words: physical inactivity, unhealthy diets, tobacco use, that were in that first slide. The paper from Goldacre et al. And you can see that, they are of long duration, they're chronic diseases, and they are from a combination of genetic, physiological, environmental, and behavior factors. So there's stuff that we can do about this. Now, the other thing is that all NCDs have something in common, and there's this triad of oxidative stress, which is essentially tissue or cellular damage from reactive oxygen species. There's an element of inflammation, and there is immune dysfunction. So if you take anything from ulcerative colitis to rheumatoid arthritis to type 2 diabetes, you will see all of these features. And you'll notice, if you're a medic, obviously a lot of people watching this aren't, but if you are, that colleagues that come to talk about their areas, whether it's a rheumatologist or a gynecologist, will often have very similar molecular diagrams up with NF-kappa B and all of these inflammatory cells, but actually they're talking about similar processes, but in different parts of the body, affecting, different systems. And what this means for practitioners is that we have to start thinking slightly differently. We have to start thinking about the body in terms of systems and how we're going to affect those systems. So all of these systems, and again, this is not exhaustive, are continuously communicating with each other, and they all affect each other. And as I say, the tools that we have are all the things that we do as human beings day to day. Now, we've got to remember the public and patients in all this. And actually, it's pretty confusing. If you look at diet alone, it's a nightmare, because, what I've just flashed up on this slide, most of it contradicts the other. So there's one here about low-fat diets better than cutting carbs for weight loss, says BBC News. And there's one about both low-carb and high-carb diets can raise the risk of early death. But then there's an NHS low-carb program, and then there's the Eat Well plate. So, who do you listen to? And the key is, it's not about one thing. It never is in medicine. It never is. It's multi-pronged. And one of the things that we've come up with on prescribing lifestyle medicine, which is an educational course that's RCGP approved, that we run for healthcare practitioners, mainly GPs, is something called the symptom web. It's very, very simple, this, but it lays out pretty much everything that leads to non-communicable symptoms or a non-communicable disease. So we've talked about diet, exercise, sleep, stress, but also there's your genes, historical infections, your environment, and your exposure to sunlight, which is sort of a euphemism for vitamin D. And what you're really looking at when someone comes in as a patient is, what I do is I lay these out, and I get this in general practice usually from their past medical history and the story that they're telling me. And I will often ask them to tell me about a typical 24 hours in their day, because it will give me really good insight into all of these factors. I've got their family history normally on the notes, and getting a snapshot of their day will tell me whether they've got a high stress job, will tell me what their marriage is like. Well, tell me whether they get enough sleep. I can see whether they've had lots of antibiotics in years gone by, which can affect your gut flora and, of course, your immune responses by looking at their past medical history. So this is a great template, I think, as a starting point to lay out all of the things that need addressing. Now, that's easier said than done because, I could sit with someone and say, you know what, you're not getting enough sleep. You're definitely not getting enough exercise. You need to eat more greens, eat less refined carbohydrates, and get out in the sun more. But actually doing it is a different matter. And what that leads to is something called a lifestyle prescription. And it's very, very simple. Usually mine are on a scrap of paper. And it involves just doing certain things. Now, the key part here is that, as I've just said, telling someone to do something is one thing, but actually getting them to do it and sustaining that change is something else. And when we look back at this slide and you look at the non-communicable diseases on this list, now some of them arguably aren't totally preventable, but they're modifiable, certainly. And even if it means that disease onset is delayed, or sometimes some of the symptoms of these conditions actually go away if those biological systems are working better. But just look at how many are non-communicable, and the effect that you could have with lifestyle prescriptions. Now, going a bit deeper into this, I talked earlier on about oxidative stress, inflammation, and immune dysfunction. How do you build immune resilience? Well, look, this is just a, off-the-cuff spreadsheet of the kind of things that will help build immune resilience. So that immune dysfunction part of non-communicable disease, which coming forward, when you look at the acute effects of coronavirus, the actual SARS-CoV-2 virus, what we need, as I said before, are really good mechanisms. We need all of these things to be working properly. Otherwise, you end up with an inappropriate immune response and hyperinflammation. So your mucosal immune system, for example, these are barriers, and what helps those? Well, moderate exercise helps that. Stress reduction helps that. Glutathione that you find in cauliflower and broccoli helps that. Mushrooms, there's also the studies on this stuff. It's not just stuff I've pulled out of nowhere. Flavonoids, which you find in lots of fruits and vegetables, a type of polyphenol, and probiotic foods and supplements, if you wish. Allicin is found in garlic, and vitamin D3, beta glucan that you find in lots of foods like green foods like seaweed, algae, and oats as well. And they actually boost things like your natural killer cell activity. So there is some science behind this. It seems very woolly telling someone to go to bed early, or, advising that they should, eat more vegetables or eat less refined carbohydrates, but actually all of those things together have this sort of magical combined effect. Now, I can't prove that it's going to actually save lives, but I've got a pretty good hunch that it will, because preventive medicine, which is really the key to the future in terms of preventing us from becoming acutely ill, we know it's very hard to research because a lot of it's prospective, but as I say, it's deliverable, it's doable. How do we do it? What are my solutions? Well, I think all clinicians need lifestyle medicine education. I think health coaches are going to be key. Now, they're the sort of missing link here and have been for years. And I'm so glad that we now have them in primary care, because they are experts in behavior change. So when you've done the lifestyle prescription and you've actually told or advised someone, look, this is what I think you should be doing more of, how you get them to sustain it is really with a bit of support. And that is what health coaches are experts at. So I really hope there's going to be a massive role for them. And what am I hoping for? Look, I'm just hoping that everyone lives longer and better, with a decent quality of life and less needless morbidity and mortality. I say needless because I'm sorry to say, and a lot of the deaths from this virus, in my opinion, have been needless. Now, I'm not going to get political about it, but it's horrific. And if there is something that we can do collectively to reduce that, to modify the chances of that happening, then we should be doing it. And there is a way of doing it. There's a programmatic way of doing it, I think, on a population basis through primary care. I'm not going to go on and on. I think those of you that know my passions and know what I do know that I'm very passionate about generalism and joining up the dots. That's what I'm trying to do here. This, I think, is a template for the future. And, you know, I think there really is hope. And I hope you've enjoyed that, and I hope that's been of some use to you. It's a bit bizarre because normally at this point there'd be a chance for questions or I could go over things, but hey, we're living in the virtual world at the moment. I'm not actually on Brighton Beach, by the way. I'm in my surgery at the moment, and this is just a mural in our hub room because myself and a couple of my colleagues actually come from Brighton. Anyway, I hope you've enjoyed that. Do stay safe, stay well, and thank you very much indeed for listening.